Okay, so here are my disclosures. So as we just heard from Dr. Evans, EGFR tyrosine kinase inhibitors has firmly established itself as a go-to treatment for patients with newly diagnosed stage 4 non-small cell lung cancer who have an EGFR sensitizing mutations. We know that EGFR tyrosine kinase inhibitors improve response rate, progression-free survival, and quality of life compared to chemotherapy. We also know that EGFR tyrosine kinase inhibitors are not forever, and eventually resistance will develop. If you can look at this slide, you can see that majority of the patients will develop resistance anywhere between 9 to about 13 months on first-line EGFR tyrosine kinase inhibitors. This is an example of what we see in patient. This is a patient who started EGFR tyrosine kinase inhibitor in November of 2009, very quickly had a response in a lung by about December, but unfortunately less than a year later progressed in a primary site again. What we also know by seeing patients and also by looking at our data is that patients progress differently. There are some patients who would progress in the brain only and still have a very stable disease systemically. There are some patients who would have something that we call oligoprogression, where the progression could be in one site or in one or two sites. And there are some patients who have something that's called a systemic progression. If one looks at retrospective analysis, about 30% of the patients will progress systemically, meaning more than one site, but majority of the patients will either progress on one or two sites or also progress very, very slowly. What we don't know, we don't have any randomized clinical trials. So we have proposed that if the patient progressed in one site, it could be reasonable to radiate that site or in some cases even resect that site and continue the patient on tyrosine kinase inhibitor. This data, although have not been confirmed by any randomized clinical trials. This is just our thoughts that if the patient tumor progresses on one site, maybe there is a rationale to radiate the site because resistance usually is not uniform. We don't have any randomized studies, as already mentioned. Majority of our trials looking at how our patients do if we continue tyrosine kinase inhibitors post-progression are retrospective studies. What we know from those retrospective studies that if your patient is progressing on tyrosine kinase inhibitor and is asymptomatic and progression is very slow, and if you decide to continue on EGFR tyrosine kinase inhibitor, you could expect about 3 to 5 months before patient starts crashing down or symptoms become more severe. This is all based on retrospective analysis. There is only one prospective study that's called Aspiration study, which actually prospectively followed patient from the beginning of the onset of the EGFR tyrosine kinase inhibitors. And patients upon progression on EGFR TKIs were allowed to continue on therapy based on investigator decision, assuming certain criteria were met. The protocol did not define by what the patient should be, but they say patient should not be clinically declining, patient should still feel well, but the final decision on continue or not continue tyrosine kinase inhibitors was still remained with the physician. So what we learn about on that study is that on average, patient can stay about 3 months on EGFR tyrosine kinase inhibitor post-progression before they start become symptomatic. You can see here that on their Kaplan-Meier curve, this is what we would expect. So the difference, if the patient started on EGFR TKI, it's about 11 months before they develop resist progression. If they meet a certain criteria and you continue on TKI, you would expect about 3 more months difference before you have to switch. The caveat, though, that this study was done before approval of osimertinib. So we really don't know in their patients who have a T790M mutation, by switching them to osimertinib, how does it change their outcomes? You saw that slide from Dr. Tracy. We know that majority of the patients, when they progress on EGFR TKI, progressed because of development of T790M mutation. T790M mutation changed the affinity of the EGFR binding pocket to first and second generation EGFR TKI, and those drugs just cannot get into the pocket because the pocket is now filled by ATP. However, there are other mechanisms of resistance that have been identified, and those are on the left side of the slide. We have seen EMT, we have seen HER2 amplification, BRAF, MET amplification, PI3 kinase, small cell lung cancer transformation either alone or with a mutation in PI3 kinase. Osimertinib. So osimertinib is an irreversible EGFR tyrosine kinase inhibitor, which works both against EGFR sensitizing mutation, and that's why we expect the FLORA data to be positive, as well as T790M resistant mutations. The one benefit of osimertinib is that it has an excellent brain penetration. The side effects of osimertinib is a little bit better in some parameters compared to first-generation EGFR TKI because osimertinib does not hit very well EGFR wild type and thus decreases the chance of EGFR toxicity such as acneiform rash and sometimes diarrhea. The benefit of osimertinib on a CNS penetration has been studied very, very extensively in the preclinical data. I show you here the comparison of monkeys models. So this is a radioactive osimertinib that was injected into monkeys. And you can see that the brain to plasma concentration in osimertinib is about 3 times. So there is 3 times more concentration of osimertinib in the brain than plasma compared to gefitinib and afatinib with the numbers less than 1. You can also see here that once somebody images the monkeys using radioactive osimertinib, so when you give osimertinib right there in the yellow, you can see that there's a very high concentration of osimertinib in the brain. This one, 1504, is an active metabolite of osimertinib. It doesn't really get in the brain very well. This is ruxolitinib, which is no longer being developed, and you can see that there is just no penetration of ruxolitinib in the brain. And then this is gefitinib, and you can see there is some penetration of osimertinib in the brain. So based on the preclinical data, we would expect a significant activity of the drug in patients with CNS metastasis. What I'm going to show you now is the data that led to approval of osimertinib, both as a data in a phase 1 trial, and also I'll show you AURA3, which is a randomized trial against chemotherapy. So those are 2 studies. There is an AURA extension, which is a phase 1 extension component, and AURA2. The primary endpoint for AURA extension was overall response rate. The primary endpoint for AURA2 was also overall response rate. So for the patients to be eligible for the study, they have to have a sensitizing mutation. They have to have progressed on EGFR tyrosine kinase inhibitor, and they have to have a documented T790M mutation. Additional criteria is they have to have a measurable disease, and they have to have a stable brain metastasis. Prior chemotherapy were allowed in both AURA as well as AURA2, but it is different from AURA3, which I'll show you in a second. And if the patient was determined to be a T790M positive, they were enrolled in a study and given osimertinib at standard dose of 80 milligrams once a day. This is what the response rate shows. So the AURA phase 1 extension showed 71% of the patients responding to osimertinib. Majority of the responses, as you can see there, were partial responses. In the AURA pooled phase 2 study, the response rate was 66%. And again, as before, majority of the patients had partial responses. This is progression-free survival. Unfortunately, and very sobering, osimertinib still does not cure patients, and eventually resistance will develop. The progression-free survival that we would expect to see from osimertinib is about 9.7 to 11 months. And you can see at 24 months, there was about 17% of the patients who still were able to remain on osimertinib. Adverse events, what we would expect from osimertinib is a slightly less incidence of acneiform rash and a diarrhea, and the numbers are described here. So you expect about a third of the patient will develop rash or diarrhea. This is for the phase 2 study. Very similar, about a third of the patient will develop very mild rash, grade 1 rash, and grade 1 diarrhea. So then we move into the AURA3 study. So this is for the patients who have had first-line EGFR tyrosine kinase inhibitor and have a T790M mutation, and they were randomized to osimertinib versus chemotherapy. So the question here is, if your patient is progressing on a first-line EGFR TKI, we know chemotherapy is effective in those patients. Would osimertinib be better than chemotherapy? Primary endpoint of the study was progression-free survival. Additional endpoints were overall response rate, duration of response, disease control rate, overall survival, and safety. This is the results of the study. So osimertinib, not a surprise based on what we already know from a phase 1 and phase 2 study, showed improvement in progression-free survival to about 10.1 months. Compared to chemotherapy by itself, progression-free survival was about 4.4 months. Response rate was also higher with osimertinib at about 71% compared to chemotherapy at about 31%. As expected, osimertinib had showed significant CNS activity. The CNS overall response rate was 54%, disease control rate was 92%, and radiation does not seem to change a response rate significantly. I think once you look at the CNS efficacy in the patients who we put on the clinical trials, you want to know how long before you measure your CNS efficacy patient received radiation, because what if you're counting the radiation effect and the shrinkage in the brain is actually caused by radiation and not by your drug. So here you can see that the patients who complete radiation more than 6 months before the first dose, so it is unlikely the response to be attributed to the radiation, response rate in the CNS was 68%. The responses in the CNS were durable, so at about 12 months, about 56% of the patients who had a CNS response were still responding. The median CNS PFS has not been reported to date. So now the question is, majority of the patients who enrolled in osimertinib trials were positive for T790M mutation. So how do you look for T790M mutation? So you have two options, and I prefer one versus another, or at least you should be aware of caveats, one versus another. So you can try to biopsy a progressing site and do molecular testing on a progressing site and see if you have a T790M mutation. Or you can do something that's called a liquid biopsy. So liquid biopsy, the scientific term for it is a cell-free DNA or circulating tumor DNA. So every day in our body, cells die, both healthy cells as well as cancer cells, and DNA is released in a circulation. So those are those squiggly lines right here. So you could do a simple blood test, collect that circulating DNA, and then sequence it and find EGFR mutations as well as T790M mutation. You need to know what's the limitation of that test in order for you to be able to accurately manage your patient. We know that sensitivity of the blood for the EGFR mutation is about 60%. We also know that sensitivity of the blood for T790M mutation is about 70%. So if you found a T790M mutation in the blood, it is in a tumor. But if you did not find it in the blood, it could be false negative. So it is very important to make sure that you continue to look for T790M mutation and you do a tissue biopsy. Another benefit of tissue biopsy is to rule out something that's called a small cell transformation, which I'll show you in a second. This is one of the examples of how can one work up a patient progressing on EGFR tyrosine kinase inhibitors. So if the patient has disease progressing after EGFR TKI, and you have a site available for the biopsy, then you go ahead and biopsy that site and then check it for T790M or a mutation. If a patient found to have a T790M mutation, you start them on third generation EGFR TKI, and the only drug currently approved is osimertinib. If the patient does not have a biopsy site available, for example, the site is too close to the major blood vessels or some other reasons that you can't biopsy the patient, then I think it's reasonable to do cell-free DNA. So cell-free DNA, although useful, does not help you rule out small cell transformation. And let's talk about a little bit about small cell transformation. So we know that patients who develop resistance to EGFR tyrosine kinase inhibitors can transform into small cell in approximately 6 to 10%. The behavior of those patients who transform into small cell is what we would expect in a patient with small cell. So they progress very rapidly and survival is not ideal. The treatment for those patients who progressed into small cell should be using small cell regimens, so a topoisomerase-based or irinotecan-based, platinum-based doublet. We know now that the small cell lung cancer for those patients is not a de novo tumor. So it's not a new small cell lung cancer that the patient developed. It's a small cell lung cancer that actually evolved out of the original adenocarcinoma. And the reason we know that, because those small cell transformations retain their original EGFR mutation. So usually small cell patients do not have an EGFR mutation. But for the transformed small cell out of adenocarcinoma in EGFR mutant patients, they retain the original EGFR mutation. There was a very nice paper published by Lee looking at the clonal origination of the small cell lung cancer, and he actually postulated that the clonal diversion for small cell lung cancer actually happens before we even started patients on EGFR TKI. So clonal predisposition exists in those patients up front. And I think it is very important that he found out that patient who has an activation in both RB and P53 increase risk in small cell transformation 43 times. So at the bottom here, I showed you patients who actually had EGFR mutant lung cancer and then transformed into small cell. And you can see yellow and gray are inactivated RB and P53. And you can see majority of those patients have both of those genes inactivated. Patients who did not transform in small cell lung cancer, majority of those patients do not have an inactivation of both genes. So that's where my plea for doing a biopsy actually come from, because by doing a cell-free DNA, you really are not excluding the possibility of small cell transformation. And for those of us who actually do next generation sequencing up front at the time of the diagnosis of the patient, you actually will have an information about P53 and RB loss. So if I'm looking at the patient who had a RB and P53 loss in the beginning, I'm more likely to push for the biopsy of that patient because I know they have a 43 times more likelihood of transforming into small cell. And there actually recent publication from Japanese authors where they looked at the 5 patients with T790M proven mutation who did not respond to osimertinib up front, and all those patients had a small cell transformation which was missed because not all of the patients had a biopsy at the time of transitioning from first-line EGFR TKI to third generation EGFR TKI. So the one question we had to answer is, before we had osimertinib available, what if we just continue EGFR TKI and add chemotherapy on top of it? So there's a trial called IMPRESS, which answered the question, and basically the trial was negative. So there was no improvement in progression-free survival by adding chemotherapy on top of tyrosine kinase inhibitors. There was actually a detriment in overall survival in patients who had chemotherapy added to gefitinib, and majority of that detriment was in a patient with T790M positive disease. Other mechanisms of resistance, there are multiple other possibilities. Unfortunately, none of those other mechanisms of resistance have a defined approved therapy yet. We had some mixed results in MET amplified EGFR-resistant population. We really have only case reports on other abnormalities. AXL is becoming more and more paid attention to. So AXL is receptor tyrosine kinase inhibitor that people think is responsible for EMT transformation. And there is actually an AXL trial from BurgeonBio looking at patients who develop secondary resistance to EGFR tyrosine kinase inhibitors. So this is kind of one of the flow charts that you can use. It will be in my slides. So basically the questions that you need to ask if disease progression clinically significant or not. So for example, if your patient is progressing by 2 millimeters every 6 months, is it time to switch? Probably not. But if the patient's progressive more aggressively, then you have to look for T790M mutation. You have to understand that liquid biopsy is helpful, but not 100% sensitive. So if the liquid biopsy is negative, you need to still look for T790M mutation. Clinical trials is the key for all our patients. In summary, at the time of progression of EGFR TKI, patients should undergo molecular testing to select next line therapy. Blood-based testing could be considered, understanding its limitation. Osimertinib is preferred to chemotherapy and immunotherapy. And I didn't show you that data, but I think hopefully it will be covered in the immunotherapy portion. Small cell transformation has happened in those patients and is more likely in patients who are deficient in both P53 and RB. We have several unsolved issues. What is the best treatment for patients who have resistant mechanisms other than T790M, and what is the best strategy for patients who progressed off osimertinib? There are mutations identified called C779S that potentially could resensitize your patient to first-generation EGFR TKI, but no fully developed studies have been reported on the efficacy of that change.